Welcome. In this session, we'll be discussing about fundus fluorescent angiography. Fluorescent angiography is based on the fluorescence property of sodium fluorescein. Fluorescence is the ability of a substance to emit light of a longer wavelength when it is stimulated by light of a shorter wavelength. Non-fluorescent substance, particularly if it is white in color, reflects the same color of light which it absorbs. So sodium fluorescent absorbs light of wavelength 465 to 490 nanometers, which is in the blue zone, and emits light of wavelength 520 to 535 nanometers, which is in the green-yellow zone. And these figures are important to remember. Sodium fluorescent is a yellow-red water-soluble hydrocarbon dye which is available as either 5 ml of 10% solution or 2 ml of 25% solution. Sodium fluorescent is a small molecule with 80% of the injected dye binding to plasma proteins, mainly albumin, and it is only the unbound sodium fluorescent which fluoresces. Unbound sodium fluorescent can pass freely through the fenestrations of the choriocapillaries, but normally unbound sodium fluorescent cannot pass through the walls of the retinal capillaries and the larger retinal arteries, the walls of the larger choroidal arteries, and the retinal pigment epithelium because of the existence of tight junctions in each of these locations. Following intravenous injection of sodium fluorescent into circulation, the sodium fluorescent in the retina is excited by blue light, which is allowed to pass through a blue excitation filter positioned in front of the white light source of a fundus camera. This blue excitation filter blocks the other component wavelengths of light from the white light source of the fundus camera, and this narrow band of blue wavelengths which the blue excitation filter allows to pass through corresponds to the peak absorption spectra of sodium fluorescent. Sodium fluorescent on stimulation by this blue light emits yellow-green light which is allowed to pass through a green barrier filter onto the camera sensor. But other non-fluorescent structures in the eye, particularly which are white in color, upon receiving this blue light from the blue excitation filter, reflects the same blue light which is blocked by the green barrier filter and is not allowed to reach the camera sensor. Instead of a white light and a blue filter, a blue laser light source can be used as in CSLO devices. We have discussed fundus camera and CSLO devices in the previous session, and we have discussed in that session how a donut-shaped mirror allows the incident peripheral light as well as the reflected central light. So this is basic to the understanding of fluorescent angiography. Prerequisites for good quality fluorescent angiogram includes a high resolution fundus camera, a skilled photographer, a clear media in the patient's eye, mydriasis which most machines require, and proper focusing with the help of crosshairs in the reticule of the eyepiece of the equipment, and a joystick which is used to center the camera horizontally and vertically to get an even illumination across the entire field provided by the camera. Before injecting sodium fluorescent, three types of images are taken: colored images as shown here in this photograph, red-free images as shown here in this photograph, which are taken with the green barrier filter in position but without the blue excitation filter, and in red-free images the contrast of surface features such as retinal vasculature, nerve fiber layer, retinal hemorrhages and exudates, and epiretinal membranes is enhanced. And images are also taken with both the blue excitation and the green barrier filter in position but before injecting fluorescent, and abnormal fluorescence in these images indicate either pseudofluorescence or autofluorescence, which we will discuss in pre-injection hyperfluorescence. A butterfly needle with a short tubing is positioned in the antecubital vein, and this is preferred because it provides ready intravenous access in case of emergency. A short tubing is preferred because it reduces the transit time of the dye. If antecubital vein cannot be accessed, veins on the back of the hand or on the radial side of the wrist can be chosen, but the time intervals of various phases of the angiogram, which we will be discussing shortly, are delayed further by a few more seconds. Any arm can be chosen without changes in the time intervals of the various phases of the angiogram, but arms with prior surgical procedure should be avoided. The syringe containing sodium fluorescein is attached to the short tubing which is connected with the butterfly needle. The photographer starts capturing images every 4 seconds, starting 15 seconds before injection of the dye, and the physician assistant injects the sodium fluorescent dye intravenously in a rapid but controlled manner to get high contrast early phase images. Getting these early phase images is important. Extravasation of dye can cause pain with potential for tissue necrosis, and this is important to remember. The photographer continues to capture images at a faster rate of every 2 seconds for the first 30 seconds, and then with increasing time intervals between captures till 10 to 20 minutes. During the first 30 seconds, only the macula or the area of interest of the study eye is imaged. Later, disc images of the study eye, then macular and disc images of the fellow eye, and finally peripheral fundus images of both the eyes are captured. This photograph is a fluorescent angiogram of peripheral fundus. Several innovations have contributed to improved imaging with fluorescent angiography, and these include confocal scanning laser ophthalmoscope, in which instead of white light source, requisite wavelength laser beam is used as a light source, producing maximum emission from sodium fluorescent, thus improving signal to noise ratio. CSLO also enables improved focusing of retinal vasculature due to its confocal optics, and two laser beams of requisite wavelengths can be combined to simultaneously acquire fluorescent angiograms and indocyanine green angiograms. Digital imaging allows real-time view of acquired images, editing, easy transmission of images, and does not require physical storage of films. Ultra-wide field cameras allow detailed assessment of peripheral non-perfusion and neovascularization, and is particularly useful for diabetic retinopathy. Video angiography is also available. The sequential phases in a normal fluorescent angiogram are the choroidal phase or the prearterial phase, the arterial phase, the arteriovenous phase, the venous phase, the recirculation phase, and the late phase. We will be describing each of these phases individually, but first we will see a sequence of images. The dye first reaches the choroid and we see the choroidal flush, but the retinal arterial system and the retinal venous system is yet to fill with the dye and appear dark. Then the retinal arteries start to fill. And progressively the retinal arterial system completely fills, but at this stage the retinal veins are still dark because retinal venous filling has not yet started. Then the retinal veins fill and the first pass of the fluorescent dye through the retinal circulation is complete. Here we note that the central region of the fovea appears dark, which we will be further discussing. So the sodium fluorescent dye first enters the eye through the short posterior ciliary arteries 8 to 12 seconds after initiation of injection and reaches the choroid and the optic disc. So this is called the choroidal or the prearterial phase, in which the retinal arteries and the retinal veins appear dark. This choroidal or prearterial phase is characterized by patchy filling of the choriocapillaris lobules as seen here in this photograph, followed by leakage from the choriocapillaries which have fenestrations, and ultimately staining of the Bruch's membrane and the choroidal stroma. And this pattern of filling is called choroidal flush. Because of this leakage of dye from the choriocapillaries, staining of Bruch's membrane, and relative blockage of green light by the retinal pigment epithelium, details of the larger choroidal vasculature is obscured in fluorescent angiography. A vertical zone of slightly delayed filling may be observed passing through the papillomacular zone or the optic disc, representing the watershed region between the medial and the lateral posterior ciliary arteries. Cilioretinal arteries, which arise from the posterior ciliary arteries and supply the inner retina, fills in the prearterial or the choroidal phase before retinal circulation fills. And as we have mentioned, the retinal arteries and the retinal veins appear dark in the choroidal or the pre-arterial phase. In the arterial phase, the retinal arteries begin to fill 1 to 3 seconds after choroidal circulation and between 11 and 18 seconds after initiation of injection in a normal retina. The retinal arteries, precapillary arterioles and capillaries fill sequentially in this phase, and the retinal arterial system fills completely within 1 second. The choroidal flush persists, but the retinal veins are yet to fill and remain dark. In 1 to 3 seconds after complete arterial filling, the veins start to fill in a laminar pattern as shown here in this photograph. And this laminar pattern is said to occur because unbound sodium concentration is more along the blood vessel walls where the blood flow is less rapid. In this phase, fluorescence from the retinal arteries is maximum and the choroidal flush is still present in the background. In the next 5 to 10 seconds, the laminar areas widen in the periphery of the veins and merge together, and venous filling thus becomes complete as shown here in this photograph. The retinal arteries and the choroidal flush remain visible in this phase. The venous phase overlaps with the peak phase, which occurs 20 to 25 seconds following initiation of injection, and in the peak phase, the filling and visibility of the perifoveal capillaries are the most prominent. The foveal avascular zone is the central 300 to 500 micron diameter area where retinal circulation is absent. So the retinal vessels terminate at the edge of the foveal avascular zone. This is because, as we have discussed in the session on anatomy of neurosensory retina, this area of the retina is composed of only the photoreceptor layer and the outer plexiform layer, which is supplied by choroidal circulation, and the inner layers of retina, which are supplied by the retinal circulation, are absent in this region. And the lack of fluorescence of this area is enhanced by a darker background because of increased amount of xanthophyll in the retina in this region and increased amount of melanin in the underlying retinal pigment epithelium, and this is very important to remember. So first pass of sodium fluorescein through the retinal and choroidal circulations is completed within 30 seconds following injection, and in the subsequent recirculation or mid phase there is progressive decrease in fluorescence due to recirculation of the dye between 2 to 4 minutes after initiation of injection, following which we have a late phase occurring after 10 to 15 minutes following injection, in which the retinal and the choroidal circulations are generally devoid of dye, as a result of which the contrast of the retinal circulation as well as the choroidal circulation with hyperfluorescent areas such as the FAZ is reduced in late phase as compared to an earlier phase, and any dye that remains in the eye in the late phase is said to be extravascular and is called staining of the tissue visible in this phase. Late staining is normally visible in the optic disc region because the optic disc is not covered by the retinal pigment epithelium, and late staining is typically observed in the optic cup, the optic disc margin and the peripapillary crescent. In these areas, the sclera is visible and the sclera contains abundant collagen which retains sodium fluorescein. But in lightly colored fundus, late staining of the remainder of the sclera as well as the choroid and Bruch's membrane become more prominent, and staining of sclera may be visible as silhouetting of large choroidal vessels against the sclera as background. So this chart shows the various phases and their time intervals following initiation of injection of the sodium fluorescent dye in the antecubital vein. Abnormal fundus fluorescence can be hypofluorescence or hyperfluorescence. Hypofluorescence is further divided into blocked hypofluorescence and vascular filling defects, and hyperfluorescence is further subdivided into 5 subtypes: transmission hyperfluorescence, leakage, pooling, staining, and pre-injection hyperfluorescence. Hyperfluorescence is a reduction or absence of normal fluorescence. Blocked fluorescence occurs due to a material obstructing visualization of fluorescin in the circulation. Unlike filling defect, fluorescin is present within the circulation in the affected area but is blocked from view by the material, and the shape of the area of the blocked fluorescence corresponds to the shape of the blocking material. The blocking material is usually visible in the corresponding area of the color photographs, and this is often important in differentiating blocked fluorescence from vascular filling defect and is important to remember. In this angiogram, we find a blocked fluorescence from a small vitreous hemorrhage which blocks the underlying choroidal and retinal fluorescence. Blocked fluorescence can occur from hemorrhages, as we have seen in the previous photograph, melanin, lipofuscin, and fibrous tissue. These two photographs show blocked fluorescence from an area containing excess of melanin due to an RPE. This area of excess melanin blocks the underlying choroidal fluorescence, but the overlying retinal fluorescence is visible. Pattern of visibility of retinal circulation through the blocking material can help locate the depth of the lesion blocking the fluorescence. Subhyalid and sub-ILM hemorrhages block all retinal fluorescence. This photograph is that of a sub-ILM hemorrhage blocking all underlying retinal and choroidal fluorescence. Subhyalid and sub-ILM hemorrhages can be differentiated clinically because the upper level of a subhyalid hemorrhage is usually flat, but the upper level of a sub-ILM hemorrhage is round. Intraretinal dot blot hemorrhages block fluorescence from deeper retinal capillaries but not from superficial large retinal vessels. Subretinal hemorrhage, as shown here in this photograph, does not block fluorescence from retinal circulation, as demonstrated in the angiogram by the visibility of the retinal vessels in the area of the subretinal hemorrhage, but the subretinal hemorrhage does block the underlying choroidal fluorescence. Hypofluorescence from vascular filling defects occurs due to reduced perfusion through an artery, capillary, or vein, either because of an intravascular obstruction or because of absence of these blood vessels. Absence of blood vessels occur in retinopathy of prematurity. So in this area, fluorescein is either absent or appears delayed. And unlike blocked fluorescence, in vascular filling defect, no blocking material is visible in the corresponding area of the color photographs. Vascular filling defects can be in the retinal circulation, in the choroidal circulation, or in the optic disc circulation. Retinal vascular filling defects, as seen here in this angiogram, is commonly found in diabetic retinopathy and venous occlusions, and the ischemic retinal thickening from retinal arteriolar occlusions may in addition partially block the underlying choroidal fluorescence. Choroidal filling defects appear round or irregular when the obstruction lies in the choriocapillaries but appears as a triangular area with apices pointed towards the macula when the obstruction lies in the larger choroidal arteries. Optic disc filling defects can be sectoral in ischemic optic neuropathy or diffuse in other optic atrophies. This angiogram is that of a patient who had occlusion of one of the two long posterior ciliary arteries, and in this early arterial phase angiogram, there is absence of fluorescence in a vertical half of the choroid and the optic disc. Hyperfluorescence is increased or abnormal fluorescence, and as we have mentioned, is of 5 subtypes. As we will discuss, these 5 subtypes can be differentiated from one another by the change in the area and the intensity of hyperfluorescence from early phase to late phase of the angiogram. Transmission hyperfluorescence is increased visibility of choroidal fluorescence in areas of reduced or absent retinal pigment epithelium where the content of melanin decreases. The area of the hyperfluorescence corresponds to the area of the retinal pigment epithelial defect, and the area remains constant throughout the angiogram. And the hyperfluorescence appears early in the angiogram, initially increases in intensity but then decreases in intensity in later phases corresponding to the time course of the underlying choroidal fluorescence. Leakage is another type of hyperfluorescence in which there is abnormal passage of fluorescein into extravascular space through either absent or defective blood retinal barriers. Blood retinal barrier is absent in new vessels and is defective in inflamed and ischemic areas. And the hyperfluorescent zone in leakage appears in early phase of the angiogram, is uniformly diffuse and increases both in area and intensity from the early phase to the late phase of the angiogram. So in this diagram, we see the three typical examples of leakage, one from the capillary, which commonly occurs in diabetic retinopathy, one is from a choroidal neovascular membrane in the subretinal space, and the third is a central serous chorioretinopathy in which fluorescein leaks into the subretinal space through a focal RPE leak. In this early phase angiogram, we see microaneurysms of diabetic retinopathy, and in a later phase, both the area and the intensity of these hyperfluorescent regions increase. So defects in the inner blood retinal barrier lead to collection of the dye in retinal parenchyma as seen with microaneurysms, cystoid macular edema as seen here in this late phase angiogram, retinal neovascularization and tumor vessels. This photograph is that of a patient with vasculitis with severe peripheral retinal non-perfusion as shown by the vascular film defect in the angiogram, and the new vessels in the margin of the ischemic area start to leak profusely in the early phase and continues to do so throughout the late phases. And inner blood retinal barrier defects can also lead to vitreous leakage, which is localized over retinal neovascularization and tumors but is diffuse in case of intraocular inflammation. And defects in the outer blood retinal barrier in the retinal pigment epithelium leads to collection of dye in the subretinal space, as found in central serous chorioretinopathy represented by these two angiograms, with the leak seen in the early angiogram increasing in area and intensity in the late angiogram, and choroidal neovascular membranes as seen here in this angiogram series. So this is the choroidal neovascular membrane, which increases both in area and intensity throughout the angiogram. Leakage can also occur from large vessels when they are inflamed, as shown here in this angiogram, occluded or pulled by vitreoretinal traction. Optic disc leakage can occur in cystoid macular edema, retinal vascular occlusion, inflammations, tumors, and papilledema. Pooling is another type of hyperfluorescence in which there is accumulation of fluorescein in a fluid-filled space. Pooling appears early in the angiogram, and the hyperfluorescent zone in pooling appears more well defined in area, in contrast to leakage, but like leakage, it increases in intensity from the early phase to the late phase of the angiogram. So this is the typical example of pooling, a pigment epithelial detachment in which there is a split of the RPE basement membrane from the inner collagenous zone of the Brooks membrane, following which fluorescein crosses freely and rapidly across the Brooks membrane to occupy the entire available fluid-filled space. So this figure shows a pigment epithelial detachment, and in the fluorescein angiogram we see a very well defined zone of intense hyperfluorescence. The area of the hyperfluorescence does not change from the early to the late phase of the angiogram, but the intensity increases throughout the angiogram. We should be able to differentiate pooling in pigment epithelial detachment from leakage in neurosensory detachment, and both of these may occur in CSCR or central serous chorioretinopathy. Pigment epithelial detachment can occur in age-related macular degeneration and central serous chorioretinopathy, and neurosensory detachment showing a leakage pattern of hyperfluorescence can occur in central serous chorioretinopathy and exudative detachment. Retinal pigment epithelium basement membrane is firmly attached to the inner collagenous zone of the Brooks membrane, and so the pigment epithelial detachment is localized. Neurosensory retina is loosely attached to the retinal pigment epithelium, and so the neurosensory detachment is extensive. So the filling of the PED with fluorescein is more rapid, intense and complete, and occurs up to its edges because of direct leakage from the choriocapillaries. Whereas filling is slow and incomplete in neurosensory detachment, as it occurs through a localized region of a break in retinal pigment epithelium with less intense fluorescence near the edges of the neurosensory detachment. Staining is another pattern of hyperfluorescence in which there is deposition of fluorescent dye in a solid tissue which can be normal, such as the optic disc as we have discussed, or abnormal, such as disciform scar and drusen. This diagram represents a disciform scar in which fluorescence infiltrates but later in the angiogram. Staining appears late in the angiogram and persists. The area of hyperfluorescence is limited to the area of the stained tissue, and the intensity of the staining increases over time as seen in these two angiograms. Pre-injection fluorescence refers to abnormal fluorescence prior to injection, and there are two types of pre-injection abnormal fluorescence: pseudofluorescence and autofluorescence. Pseudofluorescence occurs when there is an overlap of wavelengths permitted by the excitation and barrier filters. So it may occur due to a defective blue excitation filter which allows green light to pass through, which is permitted by a normal green barrier filter, or a defective green barrier filter which allows blue light to pass through, which is permitted by a normal blue excitation filter. And pseudofluorescence occurs more prominently from light colored structures which are highly reflective, such as sclera, myelinated nerve fibers, exudates, and scars. Regular changing of filters avoids pseudofluorescence, and interval of change depend on frequency of use, usually every 5 years. Autofluorescence is the other type of pre-injection hyperfluorescence which occurs from certain structures such as optic disc drusen and astrocytic hamartoma, which have the same fluorescence property as sodium fluorescein and so can fluoresce with the same blue excitation filter and green barrier filter of a fluorescent angiography camera in the absence of sodium fluorescein. This photograph shows autofluorescence from an optic disc drusen. Routine complications of fluorescent angiography include darkening of urine, yellowing of conjunctiva, and yellowing of skin, and photosensitivity to ultraviolet light in light-skinned individuals. Mild complications which require no intervention include nausea in up to 5% of patients, vomiting in up to 0.5% of patients, pruritus, and sneezing. Moderate complications which require medical intervention and which is said to occur in 1 in 60 patients include thrombophlebitis, tissue necrosis, urticaria, and angioedema as shown in these photographs, nerve palsy, pyrexia, and syncope or vasovagal attack. Urticaria and angioedema are very important to recognize because they may be followed by an anaphylactic reaction, and whenever these two signs are detected, epinephrine, steroids, and antihistamines should be administered. And severe reactions which require intensive intervention are said to occur in 1 in 2000 patients undergoing fluorescent angiography and includes anaphylaxis, myocardial infarction and cardiac arrest, and tonic-clonic seizures. Death has been reported and is estimated at 1 in 220,000 patients undergoing fluorescent angiography, and rate of occurrence of these complications increase in patients who have experienced these side effects in previous angiography sessions. Risk of fluorescent angiography in pregnant patients is yet unknown. Precautions which should be taken prior to fluorescent angiography include informed consent, skin testing prior to the procedure, which can avoid only the allergic reactions such as urticaria, angioedema, and anaphylaxis, and that the angiographic facility must have resuscitation drugs and equipments such as epinephrine, hydrocortisone, antihistamines, aminophylline, intravenous equipment, airbag, oxygen, and defibrillator. And regular training of staff to use these drugs and equipments is very important. As we'll find when we discuss the individual retinal disorders, the role of fluorescent angiography include diagnosis of retinal disorders and disruptions of RPE barrier, select and guide therapy, particularly laser photocoagulation, and assess response to that therapy. To recap the salient points, fluorescent angiography is based on fluorescence property of sodium fluorescein, which when excited by light of wavelengths 465 nanometer to 490 nanometer emits light of wavelengths 520 nanometers to 535 nanometers. In the machine, a blue excitation filter allows only light of wavelengths 485 nanometer to 500 nanometer to excite fluorescence in the eye, and a green barrier filter allows only light of wavelengths 520 nanometers to 535 nanometers, which are emitted by fluorescence to reach the camera sensor. Normally, sodium fluorescence upon intravenous injection leaks through fenestrations of choriocapillaries and is prevented by the outer blood retinal barrier, that is the retinal pigment epithelium, to escape into retina. Also, sodium fluorescence cannot leak through normal retinal vessels, including retinal arteries, capillaries, and veins, and choroidal arteries. During fluorescent angiography, before injecting the dye, color and red-free images are captured. Red-free images highlight surface features of the retina. The sequential phases which are obtained after dye injection are as follows. The choroidal or the pre-arterial phase, in which there is patchy filling of the choroid between 8 to 12 seconds after injection. The arterial phase, between 11 to 18 seconds after injection. Arteriovenous phase, in which there is laminar filling of the veins between 14 to 21 seconds. Venous phase or the peak phase, between 20 to 30 seconds. Recirculation phase, between 2 to 4 minutes, and late phase, in which there is staining of optic disc margin and cup after 5 to 10 minutes. The foveal avascular zone is the central 300 to 500 micron diameter area, which appears dark in the fluorescent angiogram because of absence of retinal capillaries, presence of xanthophyll, and increased density of RPE cells. Abnormal fluorescence can be hypofluorescence or hyperfluorescence. Hyperfluorescence can be block fluorescence due to a material such as hemorrhage or melanin blocking retinal and or choroidal fluorescence depending on the level of its location in the retina, and the blocking material is usually visualized in the color image. Or vascular filling defect, which can be in the retinal, choroidal, or optic disc circulation. Hyperfluorescence can be of 5 types. Transmission hyperfluorescence due to RPE atrophy, through which choroidal fluorescence becomes more prominent, and this appears early in the angiogram with its intensity initially increasing and then decreasing, but its area remains the same. Leakage, which also appears early in the angiogram but whose intensity and area both increase throughout the angiogram. Pooling, which also appears early in the angiogram with its intensity increasing throughout angiogram but whose area remains the same. Staining, which appears late in the angiogram with its intensity increasing subsequently but its area remains the same. And pre-injection hyperfluorescence, which includes pseudofluorescence due to defective filters and autofluorescence due to materials having fluorescence property similar to sodium fluorescein. Side effects of sodium fluorescein include mild side effects such as nausea, vomiting, sneezing, and pruritus. Moderate side effects such as urticaria, angioedema, thrombophlebitis, tissue necrosis, vasovagal attack, pyrexia or nerve palsy, and severe side effects such as anaphylaxis, myocardial infarction, and seizures. Death has been reported but is very rare. No significant contraindications to fluorescent angiography exists, including renal and cardiac failures, but fluorescent angiography should be done sparingly in pregnant and lactating women. Precautions prior to fluorescent angiography include taking an informed consent, performing a skin test to rule out allergy to fluorescent, ensuring availability of resuscitation drugs and equipments such as epinephrine, oxygen, and defibrillator, and regular training of staff to manage emergency situations. Thank you for listening.